Okay, so finally we can start. And dear students, today we will have a second part of a lecture about hemodynamic disorders. During our previous lecture, we stopped on the mechanisms of hemostasis, and we discussed mechanisms of induction of clot formation and propagation of clot formation. And what we have to discuss additionally about hemostasis and what is actually very important is limitation of clot formation, because it is very important to keep a balance uh, between attempt to block bleeding and balance between formation of the blood clot. Without limitation, this blood clot can become bigger and bigger, and if it will be not reasonably big, it can lead to formation of opposite problem. So instead of bleeding, it can lead to blocking of blood supply and ischemia. And this is also not favorable result. That's why hemostasis is not only about stopping of the bleeding with the help of blood clot, thrombocytes, and coagulation factor activation. It also contains extremely important mechanisms of limitation of clot formation. So let's look how this limitation of clot formation occurs. Let's imagine that here we see blood vessel with thrombocytes that aggregated together, and these black lines represented by fibrin depositions that arise from activation of coagulation system. How this formation of blood clot can be limited? Also, let's consider that surrounding epithelial cells are not damaged. So let's imagine that epithelial cell in direct contact with this blood clot was damaged, but surrounding epithelial cells are not damaged. Those epithelial cells that are not damaged, they will produce biologically active molecules that will limit further increase of the blood clot. For example, here you can see schematic illustration of epithelial cell, endothelial cell, that produce so-called tissue plasminogen activator. Tissue plasminogen activator will stimulate transformation of not active plasminogen into active plasmin. And plasmin will facilitate degradation of fibrin. And the fibrin degradation is one of the mechanisms that limit formation of the clot. Dear students, please switch off your microphones because I hear background noise from someone of you. Dear students, please, okay, now it's much better. Thank you. Also, I want to show you another way how healthy or not injured endothelial cell will limit clot formation. During our previous lecture, we discussed that fibrin is very important component of clot formation because it makes aggregation of activated thrombocytes more stable, more strong. And fibrin is end product of coagulation system activation. Fibrin is created from fibrinogen, so fibrinogen is not active compound of coagulation system. Under the action of thrombin, not active fibrinogen will be transformed into fibrin, and fibrin will support clot formation. How we can limit these events? Again, not injured endothelial cells, they produce a compound that is called thrombomodulin. Thrombomodulin modulate activity of thrombin in such way that thrombin that was modulated by thrombomodulin will not further support transformation of fibrinogen into fibrin. And this also will prevent further production of fibrin that is necessary for increase of the blood clot. Another important mechanism that associated with limitation of clot formation. So let's imagine that there is a healthy vessel. It was damaged by some event, and when endothelial cell is damaged and die, it will expose structures that normally hidden uh, under endothelial cells. And these compounds are full of with special proteins that activate coagulation system. So look, there was healthy endothelial cell, it was damaged and died, and now we see what is located under this endothelial cell. For example, tissue factor that activate coagulation system and von Willebrand factor. So these both factors, they are very important for blood clot formation. For example, this von Willebrand factor that normally hidden under endothelial cell, this von Willebrand factor is very important for activation of thrombocytes and their aggregation. How we can try to limit this situation? In order to limit this situation, we can produce some biologically active compounds that will inhibit activation of thrombocytes. And this is what is done by not injured endothelial cells in close proximity to the region of the injury. So we can say that injured endothelial cell will stimulate clot formation, but surrounding endothelial cells that are not injured, they will try to limit clot formation with the help of several mechanisms. So they can produce tissue plasminogen activator. They can produce also another compound that we discussed, thrombomodulin. And this is their way to decrease activity of coagulation system. Also, endothelial cell can produce compounds that will decrease activation of thrombocytes. So there are two main players in the blood coagulation system that form fibrin and thrombocytes. And endothelial cells, they can produce inhibitors of both of these systems. They can produce compounds that will limit activity of blood coagulation system, and also they can produce compounds that will limit activation of thrombocytes. And as you can see here, for example, not injured endothelial cells can produce prostacyclin. Also, they can produce nitric oxide and adenosine diphosphatase. And all these compounds, they will inhibit activation of thrombocytes. So as you see, uh, not injured endothelial cells, they can suppress activity of both thrombocytes and proteins that are necessary for coagulation and formation of fibrin. And also a very important role of not injured endothelial cells is that they hide von Willebrand factor And another component that potentially can activate coagulation proteins of the blood and activate thrombocytes. So, in addition to their uh, production of inhibitors, they also make kind of mechanical protection hiding those compounds that can lead to activation of blood coagulation, simply hiding them under their surface. And now let's start discussion about thrombosis. So thrombosis is a severe problem. I would say is a problem that have a wide range of manifestations from very mild to very severe, depending on the size of the thrombi and location where this thrombosis will occur. So if it will be kind of very small, tiny thrombi, it may no lead to some clinical manifestations. But if it will be huge, big thrombus that blocking important vessels, this may lead to extremely severe consequences up to the death of the patient. So what is the three prerequisites or three main players in formation of thrombi? They are abnormal blood flow, hypercoagulability, and endothelial dysfunction. Let's start from endothelial dysfunction. What is it? As we just mentioned a few seconds ago, normal, not injured endothelial cells, they do do their job aiming to inhibit activity of thrombocytes and inhibit activity of coagulation proteins of the blood. So when they are not injured and when they function in normal way, uh, their their job or their effort is to prevent formation of thrombi. And this is what we call antithrombotic gene expression pattern. This means that when endothelial cells are healthy, they use those genes in their genome that responsible for prevention of thrombosis, for limitation of blood clot formation. So they activate such gene that responsible for proteins that limit formation of blood clots, that inhibit activity of platelets, that inhibit activity of coagulation proteins. But in case of not normal functional activity of endothelial cells, that we call endothelial dysfunction, gene expression pattern of these cells will be changed from antithrombotic to prothrombotic. What does this mean? This means that in case of endothelial dysfunction, these cells will activate genes that encode proteins that stimulate coagulation, that stimulate activation of thrombocytes. So instead of those genes that prevent thrombosis, in case of endothelial dysfunction, these cells will activate genes encoding products that stimulate a blood clot formation. And immediate question, why this may happen? So what can be reasons for endothelial dysfunction? And these reasons can be summarized in this table. So one of obvious reasons is physical injury of the vessel. Another reason is represented by infectious agents that can damage endothelial cells, for example, with some types of toxins. Not normal blood flow. In case of turbulent blood flow, this powerful turbulent blood flow also may lead to low grade but prolonged mechanical damage of endothelial cells. Of course, inflammatory mediators, if there is inflammation going somewhere around the vessel, these inflammatory mediators will have action on gene expression pattern of endothelial cells. Also some metabolic abnormalities and toxins. So now let's speak in a little bit more details about prothrombotic gene expression pattern of endothelial cells. So what is this? How it works? This works through decrease of activity of those genes that normally should prevent thrombosis. For example, thrombomodulin that inhibit blood coagulation system. This thrombomodulin, its expression will be decreased. So endothelial cells, in case of their dysfunction, they will decrease their activity aiming to prevent thrombosis. Yeah, so when thrombomodulin expression is downregulated, this will lead to prolongation of thrombin activity, and this will lead to increase of coagulation and stimulation activity of the platelets. So consequence of this. Another event that may happen in dysfunction of endothelial cell is upregulation of plasminogen activator inhibitors expression. Once again, we have plasminogen, and with the help of tissue plasminogen activator, this plasminogen should be transformed into plasmin, and plasmin should destroy fibrin. Fibrin that is necessary for clot formation. So let's go through this chain once again. Fibrin is necessary for clot formation, and it is destroyed by plasmin. And in order to get plasmin, we need plasminogen plus tissue plasminogen activator. Tissue plasminogen activator is product of endothelial cells. And in case of endothelial dysfunction, amount of this tissue plasminogen activator that is produced by endothelial cell will drops down. So we can say that there will be no efficient amount of tissue plasminogen activator. Without this, plasminogen will not be transformed into plasmin, and plasmin will not degrade fibrin. You see? So in case of endothelial dysfunction, will happen block of uh, of those functions of these cells that are necessary to limit clot formation. And when inhibition of clot formation is limited, oppositely, there will be higher probability of exaggerated formation of blood clot. Abnormal blood flow, also important factor that increase probability of thrombi formation. And abnormal blood flow can be of two types: turbulent blood flow and stasis. Uh, Turbulent blood flow is associated with endothelial injury or dysfunction. So usually, long-lasting turbulence of the blood flow lead to endothelial injury or dysfunction. And this may increase probability of arterial and cardiac thrombosis. Stasis is more typically for venous blood flow, and how stasis support probability of thrombosis. In case of the stasis, there will be slowdown of washout of activated clotting factors. So they will be accumulated in certain location of the vein because their washout will be reduced due to very slow movement of the blood. And another consequence of the stasis is that platelets more often come into contact with endothelium. And if turbulence is associated with higher probability of thrombosis in the arterial and in the arteries, stasis associated with higher probability of thrombosis in the veins. Hypercoagulability. So what is this? Hypercoagulability is kind of abnormally high tendency of the blood to clot. From our previous lecture, you know that inside of the blood there is a system of blood clotting proteins that usually present in not active state, but in case of endothelial injury, they will start to activate each other, and as end of this chain of activation will be formed fibrin. Fibrin that makes thrombocyte aggregation more strong. So hypercoagulability is such condition when this, I would say, when activation of coagulation protein in the blood is more probable than usual. For example, in case of normal activity of coagulation protein, you need, let's say, mild damage of the blood vessel. But very limited damage of blood vessel will not lead to pronounced activation of blood coagulation protein. However, in case of hypercoagulability, very tiny damage of blood vessel may lead to not reasonably high activation of blood coagulation protein. So this is what we call abnormally high tendency of blood to clot, and this is caused by alterations in coagulation factors. So most likely this is due to some genetic we can say disorder or genetic susceptibility for increased activity of blood coagulation proteins. So in general, we can say that this has usually genetic background. This condition of hypercoagulability usually has genetic background. And this condition is considered to be a risk factor, low but still risk factor for arterial and intracardiac thrombosis, but it is considered to be a high risk factor for venous thrombosis. Also, dear students, I want to make a short remark that you do not have to try now to remember all what I'm saying to you, because there is a lot of information and you will be overloaded very fast if you will try to remember this. What you have to do, you have to follow my explanation in order to understand general concepts. So when you understand general concepts, then you can look my video lecture again in order to memorize them. But now your task is not to memorize, not to remember all what I'm saying. What you have to do, you have to follow my explanations and to understand these concepts. Let's go further. As I just told you, usually hypercoagulability is condition caused by certain genetic background, and this we call primary hypercoagulability. But there is also so-called secondary hypercoagulability that caused not by genetic background, but some problems. Examples of primary hypercoagulability states is mutation of factor V, mutation of prothrombin, increased levels of some coagulation factors. Reasons for acquired hypercoagulability is, for example, prolonged bed rest or immobilization, myocardial infarction, atrial fibrillation. So these pathologies also associated with higher probability for exaggerated activity of blood coagulation factors. Another pathologies that associated with secondary hypercoagulability are heparin-induced thrombocytopenia, disseminated intravascular coagulation, antiphospholipid syndrome, also tissue injury, prosthetic cardiac valves, and some types of cancer. These all conditions may lead to increased activity of blood coagulation proteins. What is the fate of the thrombus? So what will happen when thrombus start to be created? It can become bigger, and this is what we call propagation, enlargement of the thrombus. Another way what may happen with thrombus is dissolution. So due to activation of fibrinolytic factors, thromb can be dissolved, but this works better with newly formed thrombi. Those thrombi that are present during long time, they become more strong and they are less likely to be diluted with fibrinolytic factors. And this is actually has clinical significance because if you have a patient with freshly formed thromb that leads to clinical manifestations, you need to administer fibrinolytic therapy as soon as possible. Because if administration of fibrinolytic therapy will be delayed, thromb will become more strong and so-called old thrombi, they are resistant against fibrinolytic factors. So that's why there is so-called golden time, few hours, when fibrinolytic therapy is efficient, and then time will work against efficiency of fibrinolytic therapy. Next, what may happen with thromb is so-called organization and recanalization. So they may happen in growth of endothelial cells, smooth muscle cells, and fibroblasts inside of thrombotic mass, and even small capillary channels may be formed through the thromb. Another event that may happen with the thromb is embolization. This happens in case when thromb is detached from its site of the origin and then transported somewhere through blood circulatory system. And now let's speak about embolism. So what is embolus? Embolus is a kind of detached intravascular mass that is carried by the blood from its point of origin to a distant site. And this embolus can be solid, like thromboembolus, embolus that is represented by the thromb with platelets inside that are sealed with fibrin deposition. Also, embolus can be liquid, like embolus represented by amniotic fluid, or gaseous embolus. And as consequence of all these types of embolus may happen infarction or tissue dysfunction due to ischemia. Let's now discuss one by one different types of embolism. And we will start from pulmonary thromboembolism because it's of great clinical significance. So usually, emboli that leads to pulmonary thromboembolisms, they originate from deep venous thrombosis. And most often they originate within deep leg veins that are proximal to the fossa popliteal. Let's imagine that here we see vein, and this red accumulation is a schematic illustration of the thromb. What will be further pathway of this thrombus? If it will detach from the site of its origin, it will be carried by the bloodstream from the venous system into the heart, into right atrium, then into right ventricle, and then it can be transported further into the lungs, into the pulmonary artery. And there it can be stopped in different branches of pulmonary artery depending on the size of the thromb. And of course, clinical manifestations will depend on the site where this thromb was stopped. For example, this thromb can be stopped in some mm, small branch of the vessel, or it can block bigger part of vasculature of the lungs, or it can even block totally pulmonary artery. And if a large embolus blocks a major pulmonary artery, this may lead to sudden death. Another situation that is represented by systemic thromboembolism. So systemic thromboembolism represented by thrombi that was transported by systemic blood circulation and stick somewhere outside of the lungs. Most usually, these thrombi that will be transported into systemic blood circulation originate from heart chambers. So approximately 75% of such thrombi, they originate as a result of infarctions of left ventricle. 25% of thrombin that comes from the heart and transported further into systemic blood circulation, they comes from dilated left atria. Also, some limited probability or limited amount of cases of systemic thromboembolism characterized by thrombi that originated from aortic aneurysms, thrombi that originate from ulcerated atherosclerotic plaques or fragmented valvular vegetations, or maybe even in the venous system, so-called paradoxical thrombi. Fat embolism. What is it and from where it comes? Fat embolism may happen in case of soft tissue crush injury. Also, it may happen in case of bone fractures. And these damage, two types of damage, leads to release of microscopic fat globules into blood circulation. And usually these microscopic fat globules, they are very tiny and clinically silent. But in some limited amount of cases, patients develop a systemic fat embolism syndrome. So this is a rare situation, but unfortunately this is severe situation. Fat embolism syndrome characterized by pulmonary insufficiency, neurologic disorders. It can be manifested by anemia, thrombocytopenia, and diffuse petechial rash, and in limited amount of cases, unfortunately, it can be fatal. So this happens rarely, but it should be taken very seriously if this happens. Amniotic fluid embolism. Amniotic fluid embolism is also a rare but unfortunately very severe complication with high mortality rate. So this may happen in case of entry of amniotic fluid and its content into maternal circulation when a woman is giving birth to a child. This may happen in case of uterine vein rupture or tears in placental membranes. And onset of this amniotic fluid embolism characterized by such severe manifestations as a sudden severe dyspnea, cyanosis, hypotensive shock, seizures, and coma. And if women survive after all these dramatic events, secondary complications may be presented by pulmonary edema and disseminated intravascular coagulation. Disseminated intravascular coagulation provoked by thrombogenic substances in amniotic fluid. So once again, this is rare but very severe disorder. Gas embolism. Gas embolism represented by gas bubbles within the circulation that potentially can obstruct vascular flow. And this will lead to distal ischemic injury. So if at some point blood flow through the vessel was blocked with gas bubble, distally from this point, tissue will suffer from insufficient blood supply and ischemic injury. A typical example of gas embolism is so-called decompression sickness. What is it? When air is breathed at high pressure, this leads to increased solubility of gas, and increased amount of gas become dissolved in the blood. So when a person breathes in air, being at high pressure, under high pressure, more high than usual amount of gas will be dissolved in the blood. So this typical situation for divers. So they are under higher pressure. So now let's imagine that this guy suddenly decided to come up very quickly. In this case, surrounding pressure will drop down also very fast. And when this happens, nitrogen will expand and bubble from the blood. So once again, when person is under high pressure, increased amount of nitrogen was dissolved in his or her blood. But then when pressure drops down rapidly, solubility of nitrogen also decreases very fast. And due to this decrease of solubility of nitrogen, it will be bubbled from the blood. And this is a typical disorder of such people who dive deep under the water, and they know that this is a rule that they are not allowed to come up very fast. Otherwise, this increased amount of nitrogen in their blood will form bubbles in the blood, and this may lead to blockade of blood flow in the vessels. So this may lead to formation of gas emboli and tissue ischemia. And now we will speak about another very important and clinically relevant disorder, infarction. So infarction is an area of ischemic necrosis caused by occlusion of vascular supply to affected tissue. So what can be reasons of occlusion of vascular supply. This can be arterial thrombosis, reason for this. Also, occlusion of vascular supply may be caused by arterial embolism. Uh, More rare event is venous occlusion and extrinsic compression of the vessel or vasospasm or vessel twisting. So arterial thrombosis and arterial embolism, they are more typical causes for occlusion of vascular supply that in turn leads to ischemia and necrosis. There are two types of infarcts, one that we call red infarcts or hemorrhagic infarcts, and they usually results of venous occlusions, and white or anemic infarcts, they usually results of arterial occlusion. Also, additional special case is septic infarct. This happens in case of microbial contamination of necrotic tissue. So when initially was so-called non-septic or aseptic infarct that lead to death of the cell, and then on top of it was added some type of infection, some type of microbial contamination, and this will lead to septic infarct. What are the factors that influence severity of infarct? One of the very important factors that will influence how severe will be consequences of infarction is anatomy of vascular supply, especially presence of or absence of alternative blood supply pathways. So it's obviously that if one road of blood supply is blocked, but bypass is available, this will lead to milder disorder than if there will be only one pathway of blood supply available and this only one pathway will be blocked. Also, rate of occlusion is important because if occlusion of blood vessel will occur slowly, this will give time for a tissue to establish bypass blood supply. And of course, very important factor is tissue resistance to hypoxia. So intrinsic property of tissue that suffer from occlusion of blood supply. Some tissues, due to their intrinsic property, they extremely sensitive to deficiency of blood supply, while another can be quite resistant. For example, neurons can resist to blood supply deprivation only several minutes, while, for example, myocardial cells, they can resist to blood supply deprivation 20-30 minutes, while fibroblasts can survive even several hours in these conditions. Next topic that I want to discuss with you is disseminated intravascular coagulation. Also, very severe disorder that potentially life-threaten and have to be treated immediately and with very powerful medication. So it is characterized by widespread thrombosis within microcirculation, and this is caused by systemic activation of coagulation. During beginning of our lecture today, we were talking about local formation of thrombi in local region of endothelial dysfunction. For example, if somewhere in the blood circulation there is turbulent blood flow locally, may happen endothelial dysfunctions that will lead to a local formation of thrombi. But In case of disseminated intravascular coagulation, we're talking about totally different situation. We're talking about not local formation of thrombs somewhere, but we're talking about systemic activation of coagulation factors. Activation of coagulation factors throughout all blood circulatory system. And this will lead to multiple thrombi formation in multiple tissues. And this will result to tissue hypoxia in multiple organs and multiple microinfarcts. But this is only first part of the drama in case of disseminated intravascular coagulation, because after massive activation of coagulation factors throughout blood circulatory system will obviously happen depletion of these elements that required for homeostasis. So they all were consumed during first part of disseminated intravascular coagulation pathogenesis, and then due to depletion of these elements that are necessary for homeostasis, will happen such situation when bleeding will become highly probable, and usually microinfarcts and multiple thrombosis followed by bleeding. So kind of two powerful or two severe problems that comes one after another. First severe problem is multiple thrombi formation throughout blood circulatory system with tissue hypoxia and microinfarcts. Then, when coagulation factor is depleted, this will lead to bleeding. Systemic activation of coagulation. What can be a reason for this? One reason is release of coagulation activating substances into blood circulation. Powerful, massive release of coagulation activating substances into blood circulation may lead to systemic activation of coagulation. When this may happen? This may happen in case of some obstetric complications, in some type of cancer cells, and also in case of the sepsis. Another mechanism that may lead to systemic activation of coagulation is widespread endothelial cell damage. And this may happen in case of burn injury, heat stroke, infections, also sepsis, and antigen antibody complexes if they present in very high amount. What are clinical manifestations of disseminated intravascular coagulation? Dyspnea, cyanosis, convulsions, acute organ failure, and this may happen in multiple organs, and coma, and even shock. And now let's speak about shock. Once again, I told you that today we have a lot of information. Do not try to remember everything, but please follow my explanations, and your job is to understand general concepts. Details that you forgot now, you can rework in your memory with the help of video record of my lecture or with the help of textbooks. So what is the shock? In simplified way, we can say that shock is insufficiency of systemic blood circulation. And this will lead to tissue hypoperfusion. That means decrease amount of blood supply. This in turn will lead to cellular hypoxia. Cellular hypoxia will lead to organ dysfunction. This will result in, if not treated properly, this will result into organ failure and death. Shock is severe disorder that can lead to a death. And this reason why it have to be treated appropriately as soon as possible. There are several types of shock depending on reasons for this disorder. So cardiogenic shock. Cardiogenic shock result from myocardial pump failure. So if heart is not able to pump blood efficiently through blood circulatory system, this will lead to systemic insufficiency of blood supply. And this may happen in case of intrinsic myocardial damage, for example, infarction. If blood vessels that supply heart muscle with the blood will be blocked, muscular cells of the heart will suffer from oxygen insufficiency. Then after some time they will start to die, and due to death of functional myocardial cells, the heart itself will become weaker and will become not possible. It will become not possible for heart to maintain efficient pumping of the blood throughout blood circulatory system. Another reason that may lead to myocardial pump failure is obstruction of blood outflow or extrinsic pressure on the heart. Clinical situations that typical for this case is myocardial infarction, ventricular rupture, arrhythmia, cardiac tamponade, pulmonary embolism. Another type of shock is called hypovolemic shock. Hypo means not enough, volemic means volume. So from this word itself, you can understand that hypovolemic shock is condition characterized by not enough amount of blood in the blood circulatory system. In other way, we can say low cardiac output due to loss of blood volume. This may happen in case of hemorrhage and in case of fluid loss. For example, due to severe long-lasting vomiting, diarrhea, due to trauma, due to burns. Septic shock. Septic shock characterized by overwhelming release of inflammatory mediators. And this is also called severe systemic inflammatory response syndrome. What can be reasons for such overwhelming release of inflammatory mediators? This may happen in case of severe infection, in case of severe trauma, burns, or pancreatitis and some other pathologies. So these are reasons. And what are mechanisms? Due to overwhelming release of inflammatory mediation may happen a massive peripheral vasodilatation. And this also vascular leakage. If permeability of the vessels will be increased, fluid will be transferred from the blood circulation into the tissues. And this also will lead to decrease of amount of blood volume in the circulatory system. And also, due to peripheral vasodilatation, will happen blood pressure decrease. Additionally, septic shock that was triggered by overwhelming release of inflammatory mediator may be complicated with disseminated intravascular coagulation, because these inflammatory mediators being produced and released into the blood in overwhelming amounts, they may trigger activation of blood coagulation compounds. Anaphylactic shock. Anaphylactic shock is systemic vasodilatation and increased vascular permeability due to immunoglobulin E mediated hypersensitivity reaction. It was a topic of one of our previous meeting. So in case of immunoglobulin E mediated hypersensitivity reaction may happen systemic vasodilatation and increased vascular permeability. And this will lead to dramatic drop down of blood pressure and to transfer of the blood of fluid from blood circulation into the tissue. Also, this can lead to edema. What are stages of shock? So now we're coming close to end of our lecture. What are the stages of the shock? First stage is called initial or non-progressive stage. This stage is characterized by such situation when compensatory mechanism maintain perfusion of vital organs. So due to refractory reactions, occurs redistribution of the blood in favor of vital organs. But all other organs and tissues, they will suffer from insufficiency of the blood. Progressive stage is characterized by worsening of metabolic disorders, worsening of hypoperfusion. So those tissues that kind of not was supplied by the blood not adequately, those tissues that receive not amount of blood supply, they can resist this situation for a certain time, but starting from some critical limit, they will not be able to function properly in this situation. And in this case, they may activate local mechanism of vasodilatation. And this will lead to fail of those compensatory mechanisms that guide blood to vital organs. So during first phase or first stage of the shock was performed redistribution of the blood into a favor of vital organs, but this lead to ischemia of another tissues. During second stage of the shock, those tissues that were suffering from ischemia, they will start to we can say they will start to pull blood to themselves. They will activate mechanisms of local vasodilatation, and this will lead to such situations that blood will be distributed from vital organs to another organs and tissues that suffer critically from insufficiency of blood supply. So at the beginning, vital organs take blood to themselves, but then at the progressive stage, another tissues and organs, they will try to take blood to themselves, and they will kind of take this blood from vital organs. Of course, this will be characterized by worsening of hypoperfusion, ischemia, metabolic disorders, and the final stage of the shock is so-called irreversible stage, characterized by severe hemodynamic deficit, tissue ischemia. It can be complicated by disseminated intravascular coagulation, and all this complex of severe disorders will lead to the death. So, dear students, this is the end of my lecture about hemodynamic disorders. Now,
Excuse me, doctor. Next class